Hi, my name is Dr. Enzo Fulco from Natal, Brazil. I'm an oncology service fellow at Wills Eye Institute in Philadelphia, and this video is going to talk about intra-arterial chemotherapy for retinoblastoma.
IAC stands for Intra-Arterial Chemotherapy. This is a way that we can deliver chemotherapy to the eye by entering the arterial system of the body.
So IAC is intra-arterial chemo. Practically, it's delivering the chemotherapeutic agent directly to the tumor by driving up a microcatheter all the way endovascularly through the groin, through the femoral artery, all the way up to the carotid artery, and then threading a small microcatheter in the ophthalmic artery, which is the artery that goes to the eye, and then injecting over half an hour chemotherapy directly to the tumor. This way, you're using much smaller dose of chemotherapy compared to the systemic chemo because you're delivering it directly to your target.
Well, primary treatment means the first treatment a child receives for treatment of retinoblastoma. We use IAC as primary treatment when a child comes in with unilateral retinoblastoma, opposite eye clear, one eye involved. And it's usually those eyes that have moderate or advanced disease. We classify retinoblastoma into 5 groups based on how advanced the disease is. Groups A, B, C, D, and E in increasing advancement. And we use intra-arterial chemotherapy for eyes that have group C and eyes that have group D, rarely group E. Why don't we use it for groups A or B? Because we can treat them with less invasive measures. We don't need to go to intra-arterial chemotherapy for minor retinoblastoma. The answers are, the role is great, and has it replaced external beam? Yes. So intra-arterial chemotherapy, as I previously mentioned, can be used as a primary treatment, as the first treatment a child receives. It can also be used for recurrence, which we would call secondary treatment. This is after an eye fails standard intravenous chemotherapy, which we call chemoreduction, or after an eye fails laser, cryotherapy, plaque radiotherapy, or any of the other treatments. Well, for unilateral disease, we tend to treat most of the children with intra-arterial chemotherapy. I would estimate 80 to 85% of unilateral retinoblastoma receives intra-arterial chemotherapy as primary treatment. For bilateral disease, we tend to start with intravenous chemotherapy, that is chemoreduction. If they fail intravenous chemotherapy with recurrence in the eye of retinoblastoma, then we will use intra-arterial targeted chemotherapy. I think there's 2 subsets of children who does best. The first subset are those with unilateral disease, groups C or early group D. They do best. Their eye is salvaged with usually 2 or 3 doses of intra-arterial chemotherapy. But not only is their eye salvaged, their life is salvaged. And they avoid multiple other treatments. Just 2 or 3 doses of chemotherapy cures these children. It's remarkable. The other group that does very well with the IAC are those that have failed chemoreduction. Again, these are eyes or children with eyes filled with retinoblastoma who are facing removal of the eye or external beam.
So the 2 challenging steps are first to get access to the groin, and sometimes in small babies that are less than a month old, you can have difficulty accessing the groin, and then some patients will have an acute angle of the takeoff of the ophthalmic artery from the carotid, or a 360 loop, so this would be also challenging to catheterize. It depends on the age of the patient. It depends on how easy is the access to the groin, and then how easy is the access to the ophthalmic artery, but it can take anyway from 45 minutes to a couple of hours.
So the baby looks completely normal, except for the fact that sometimes they can have a little bit of swelling on the eyelids and the area around the eyes.
There are severe immediate complications. The severe complications are retinal vascular obstruction or ophthalmic artery obstruction.
So the parents' main concern for IAC is the risk of death or stroke. And we normally tell them that so far we haven't had any cases, fortunately.
It's very exciting. It's opening the horizons to us, interventional radiologists and neurosurgeon. I'm a neurosurgeon. I used to never be involved in retinoblastoma, and here I am now. I'm involved in a really ocular disease. It's a promising technique, and I think it's a revolution on how we're treating retinoblastoma.
I'm ecstatic. This has been a revolutionary alternative for children with retinoblastoma. Children who would have otherwise had their eyes removed are now having the eyes saved with intra-arterial chemotherapy, or those who would have otherwise lost vision or had complications from external beam radiation now have very few complications with intra-arterial chemotherapy. This has totally changed how we manage children with retinoblastoma. I give credit to our colleagues around the world who have worked alongside with us in investigating this very important new therapy for retinoblastoma.
In summary, a new chapter has been written with the introduction of intra-arterial chemotherapy as a treatment for retinoblastoma. It has proven to be a powerful treatment with good tumor control and minimal systemic complication. The exact role of IAC awaits further definition.